Thank you so much for joining. Apologies for the little delay we have had. We were trying to fix few things. So we are happy that we are all here. Maybe before we take this 5 minutes to know one another, may I introduce myself? I'm Sandile Mahlangu, working at Eswatini Hospice at home, and also I am the Eco Hub coordinator for Hospice. So I will be leading today's session to assist us all have opportunity to learn and share our experiences. May I say that feel welcome and feel free to share with us whatever you think is discussed and you wish to share it with us. Today we will be looking at a biopsychosocial spiritual approach and assessment within the context of providing supportive care to the patient and our loved ones. We are looking forward for a great module that we will be doing for the next coming days. Let me just say that our module calendar is available in IECO platform. You can open in IECO.org and then you'll see that we will be running this session till around November. So we'll be having these alternative weeks of being together. So we are looking forward to get more and more time together and share our experiences and cases. Last session, we were doing and looking at interdisciplinary team, which was our opening session for this module to help us understand that in palliative care, we need one another, and each and every member of the IDT has a role to play, regardless of the approach. Maybe can be adapted or be adaptable in our different settings, whether you are using the IDT or we are able to use multidisciplinary. But the core thing is that at the end of the day, we need to work together. So for that reason, may I welcome everyone. But maybe I will give individuals here to greet us and share their experiences, who they are and where are they joining us from today. If ever there are members they are joining with, maybe share with us the names of those people they are joining with. We are requesting that if you are in a group and then we have our scribe in a group, may she or he be able to type your names on the chat so we can be able to know whom are we joining with today. So I will start with the team that I'm with in this room. Maybe they will introduce themselves, starting from my right to the other side.
Good afternoon, colleagues. My name is Devan Namabuso, and I'm part of the ECO.
Thank you. Yeah. Another one.
Good afternoon, colleagues. My name is Messi Shabamu, and I'm with the Hospice Hub team.
Thank you. Welcome, Messi. And then I have many, and I will try to show you here. Yes, another one.
Good afternoon, colleagues. My name is Praise Muchono, and I'm with the ECO team.
Yes, thank you, Praise. Yes, here's another one. I'm showing you, colleagues, so you can see I'm not alone.
Good afternoon, colleagues. My name is Simple Mabuso, and I'm with the ECO team.
Thank you, Simple. May I jump to our big team from Good Shepherd Home-Based Palliative Care team? May you introduce yourselves?
All right. Okay, afternoon, everyone.
You're welcome.
Yes, my name is Chonge. I'm a nurse here at home based care, palliative care. I'm joining on behalf of the team. Unfortunately, the team couldn't join today. They are doing home visits, but I will be representing them today.
Welcome, Dimanze. We are happy to have you here. May I go to Cyprian? Mr. Matsenjo, can you hear me? Mr. Cyprian, can you hear me, sir? We can't hear you. Maybe you can mute yourself. Yes.
Yes, my name is Cipriano Marinjo. I'm working at National Control Paban as a patient navigator. Thank you.
Thank you so much, Mr. Matsenjo, to have you today. And then we have Zex Mkonta. Zakele. Zakele, do you hear us? Mr. Mkonta. What does that say? Mr. Pungwayo.
Good afternoon, ladies and gentlemen. I'm Pius with the EcoHub team.
Thank you. Thank you so much. Mr. P.
Good afternoon, team. My name is Pennington Lamini, Eswatini.
Thank you so much, Mr. P. Nestandazile.
Good afternoon, Tim. That's Milani from Manzi Hospital. And we are, of late. We hope about engagements actually engaged with. Otherwise, I'm joining with, we have Nelly Somatendra. She's a mental health nurse. So we have another nurse, but she is not here today, but you might be seeing him on other sessions. So do expect, if I cannot join, they'll be joining you from the government.
Thank you. It is nice to hear that today we also have a mental health specialist nurse who will gonna help us big time. Okay, we also have Anita. Would you like to greet us, David? Anita. Simran, would you like to greet us?
Hello, everybody. My name is Simran. I'm audible to you.
Yeah, thank you, Simran, but we couldn't get you well. I don't know whether it's our network or your network that side. Yeah, but we can request that we can introduce ourselves on writing our names on chat and those who are joining with. Welcome everyone. Today, we are going to look at biopsychosocial spiritual assessment or approach towards assessment with the intention to provide psychosocial support to our clients. So we have been covering different modules in the past. So we have covered pain assessment and management. You can visit our IECO platform to see those resources, or you can visit our YouTube channel where we upload every session video on Eswatini Hospice at Home. We have those videos since we started in 2022. So we also have those resources we have even conducted previously in our IECO platform. May we also introduce to you, colleagues, the Android application for IECO, which makes joining and accessing the materials very easier. So you just download it and you have it in your phone, and then it helps you to have access and be able to join the session with ease because it's already there in your phone. Once you are registered in the platform, you can even select those programs you want to join. So we are introducing it to you. You can go to Play Store and download it, and then you will have it in your pocket 24/7. That's what we can introduce to you. And we are requesting that if ever you have registered to the platform only with your cell phone number, we are requesting that if possible, you can add your email, so it can help us also when we have completed pre and post tests, so that we can share with you your certificates and be able to share different communications. And your email also will help us be able to ensure that you receive the instant reminders that comes 30 minutes before. During the session, you are free to write in chat, and you are also free to raise your hand when time for discussion. So for now, I will give Mercy to do the presentation, and after the presentation, we will have our case presentation for the day. Thank you. Apologies for the delay, colleagues. We are trying to share the, can you see the presentation that side?
Good afternoon, colleagues. My name is Mercy Shabangu, as I've introduced myself earlier. Today I'll be sharing a presentation on the biopsychosocial spiritual approach for palliative care assessment. Our presentation today will focus on these aspects without really getting deep into maybe the kind of assessment. We are going to focus on the approach more. And then I think we'll also get time, maybe moving forward, to then look at the assessments in depth. Okay, so we are going to look at the definition of what the biopsychosocial spiritual approach is. So the biopsychosocial spiritual is defined as an approach in palliative care as a holistic model which is designated to address the complex needs of patients with chronic illnesses and their families. This definition proposes that individuals' health and their well-being are influenced by a combination of biological, psychological, social, and spiritual factors. This holistic model to patient care tends to focus on their intrapersonal interactions of the physical body and the mind-body connection, and also the patient's extrapersonal relationships with the physical environment, family, friends, and communities. So basically, this model recognizes that health outcomes cannot be solely attributed to biological factors, but instead they result from a complex interaction of multiple factors. And when you look closer to the biopsychosocial spiritual approach, it goes beyond separating the physical from the mental, social, spiritual experiences of the client. So we're going to look at the significance of this model in palliative care. The significance of this approach in palliative care is that it explains how a client may experience pain without an identified physiological cause. And it can also explain how clients may experience differing pain levels compared with others within the context of the recognized disease or injury. This basically means that clients may have the same diagnosis and possibly there's a similar trajectory, but the way in which they experience or their experiences will differ, and also their treatments or interventions will also differ. Patients are considered as beings in relationship, and illness is regarded as a disruptive force in the biological relationships that can impact all the other relational aspects of the patient. Hence, a holistic approach to care is very important. When we talk about pain management in palliative care, we talk about issues of total pain, which describes or incorporates the biopsychosocial and spiritual phenomenon of pain experience. Since the psychosocial spiritual aspect of the client tends to influence the pain experience during the disease trajectory, this then can cause limitations of appropriate use of opioids and the potential role of patient narratives in the total pain experience. So this would be, so the significance of this model in palliative care is to ensure that we don't find ourselves prescribing drugs for spiritual needs or social needs that need other assessments and approaches. Now we're going to look at the biological aspect. The biological aspect of palliative care focuses on mitigating symptoms and improving the quality of life of the patients. This may involve pain management, which could be pharmacological and non-pharmacological. It also includes symptom control, symptoms like constipation, nausea, wound care. These are some of the symptoms we have discussed in our previous sessions. So in this aspect of care, We look at pain management, symptom control, and addressing any physical discomfort that the individual may be experiencing. By addressing the biological aspects of care, healthcare providers can help alleviate suffering and improve the patient's overall well-being. Now, this requires coordination with medical professionals to provide appropriate medications, therapies, interventions, as well as assessment. Then there's the psychological aspect of this model or approach. The psychological aspect plays a crucial role in the socio-spiritual approach to issues of health and well-being. It focuses on factors that encompass an individual's emotions, thoughts, and behaviors, and also how they interact with biological, social, and spiritual factors to influence an individual's overall health outcome. These factors, the psychological factors, may include stress, beliefs, and attitudes towards health, mental health, coping strategies, and the client's personality. Patients and their families may experience feelings of anxiety, depression, fear, and grief as they navigate the challenges of their illness. So by providing psychological support, we as healthcare providers can help individuals cope with their emotions and improve their mental well-being, which also improves their quality of life. Psychological support that can be provided can include counseling, psychotherapy, support groups to help patients and their clients cope with the emotional burden of the illness. So it is important, colleagues, that we understand that this approach is actually applicable to all of us as members of the MDT or interdisciplinary team. So whenever you come across a client, you are expected to do a comprehensive assessment and look at all the aspects of the client. So if there's areas, for example, like this psychological aspect on issues of psychotherapy, when we talk about intervention, this is where you are able to refer the client to the psychologist or social worker. So it is not an issue that maybe you might feel like some of the issues you cannot be able to attend to them, but you can refer them to the other member of the interdisciplinary team. Then when we move to the social aspects, the social aspect of palliative care recognizes the importance of social support in helping patients and their families navigate the complexities of their illness. This aspect focuses on factors that relate to an individual's social environment, including their relationships, community, and cultural context. The factors may include social support, the client's socioeconomic status, their cultural beliefs and practice, issues of neighborhood safety, employment and work-related stress, social isolation, and access to healthcare. So it is important that as we are engaging our clients, or as we are taking care of our clients, we need to be aware of what is happening to them in these aspects, because you might find that you might assess and prescribe an opioid only to find that the client has issues when it comes to access to healthcare. Maybe they live far from the facility and they won't be able to probably come back for a refill or even do tests in time. So it is very important to also look into the aspects of the social aspects of the client. There's also issues like employment and work-related stress. Some of our clients are still working, and some of them have even lost their jobs because of the illness. So you cannot just treat the physical pain and ignore this issue that the client is facing. Also, issues of cultural beliefs and practice have a very huge impact in terms of adherence to treatment. So before you even give a client any therapy, or whatever form of intervention without knowing what their cultural beliefs are, you might find that you are wasting those resources on the client because they might not actually use them. So by addressing the social aspects of care, healthcare providers can help individuals feel more connected and supported during this difficult time. This may involve connecting individuals with community resources, support groups, counseling services, providing crisis interventions, and family mediation to help them cope with the challenges they are facing and to ensure that their social needs are met. Clients can also be supported with practical issues like caregiving, financial concerns, and navigating the healthcare system. Then on the spiritual aspect, spirituality equates to the patient's belief system and personal values, and it plays an essential role in palliative care, regardless of one's faith. Common issues are that clients often struggle with loss of self or forgiveness, self-exploration, self-balance, self-actualization, and alienation. The spiritual aspect of palliative care acknowledges the importance of addressing the spiritual needs and beliefs of patients and their families. This may involve providing spiritual counseling, facilitating religious practices, or simply offering a listening ear to individuals as they explore their spiritual beliefs. This model acknowledges that spirituality can actually provide a source of comfort, hope, and meaning, and it can influence an individual's coping mechanisms, social support networks, and overall quality of life. By addressing the spiritual aspects of care, healthcare providers can help individuals find meaning, purpose, and comfort as they navigate through their disease trajectory. So now we are going to look at how we can apply this approach in palliative care. So there's comprehensive assessment. Here you can conduct an initial and ongoing assessment to understand the patient's needs across all 4 domains. And it is key to collaborate with the IPT or the interdisciplinary team, which could include doctors, nurses, dietitians, pharmacists, social workers, psychologists, chaplains, and even the loved ones of the client. Then there's also individualized care plans. Here we develop care plans tailored to the unique needs and preferences of the patient and family. We ensure that all aspects of the client or of the patient's well-being are addressed. Then another means to apply this approach in palliative care is through communication. As we all know, communication is sort of like the background, or the backbone of palliative care. So it is important to engage in open and empathetic conversations for effective communication with patients and their families about prognosis, treatment options, and care preferences. It is also important to provide information and educate the client and their families about the illness and about the services available. When it comes to support systems, facilitating support groups and community resources for patients and their families is very beneficial. And offering respite care and assistance for caregivers helps reduce burnout and stress. So when we come to cultural sensitivity, respecting and incorporating the cultural, religious, and personal values of the patient and their family into our care plans is one of the main things that we should not overlook. Being aware of and addressing potential cultural differences in perception of illness, death, and dying makes it easier when it comes to goals of care and when it comes to advanced care plan discussion. In conclusion, the much focus on biological aspects of pain management at the expense of psychosocial and spiritual aspects results in under-assessing and under-treating other areas that contribute to the experience of total pain and related suffering. By integrating the biopsychosocial-spiritual approach, palliative care providers can offer more comprehensive and compassionate care, addressing the multifaceted needs of patients and their families during challenging times. So this approach gives us a new opportunity to alleviate most of the suffering that our clients experience. Thank you.
Thank you. Thank you so much, colleagues, and thank you so much for the presentation, Mercy. Mercy is our social worker here at Hospice at Home. So she does the good work that we don't know as far as social work is concerned. So I'm happy that now she has shared with us this model. Actually, what she's trying to share with us, you can stop sharing the screen. A moment, colleagues, we are trying to sort another issue here. We are saying what have we done here? Okay, thank you so much. I was trying to say, thank you so much, Mercy, for what you have just shared with us. And we appreciate what she has already shared. I hope most of us, we can relate to what she has already shared with us. Actually, this one is a tool to help us understand how best we can practice interdisciplinary approach and how best we can support our patients, families, and the caregivers in the community. Actually, what she's trying to say is that it is very important for us to ensure that we do assessment prior to intervention. I don't know if anyone would like to add or comment. May I open this opportunity for anyone who wants to share something? Anyone who may like to share something? Anyone who may like to share something? Yes, Sister Mbata.
for the
I don't know whether it's the network, sister. We can't hear you this side. But we can't hear you, sister. I don't know what is happening. Can you hear us? Oh, no, we have lost her. All right. Maybe we will still wait for her to log in again. We have just lost Sister Mbata. Anyone else who may want to comment or ask a question or share something concerning biopsychosocial approach and assessment in our different setting? You can even share your experience with this model. How has it been easier to incorporate the psychosocial spiritual element of a patient when you are doing your care in the settings? Anyone who may wish to? Yes, you can go ahead.
Okay, I comment on behalf of the palliative care. No, for me, it's not necessarily a comment to appreciate the scene. It was lovely, and it reminds us of the steps that we see each and every day, like how we can still this up on like by focus on the scene, like holistic approach. Basically a reminder for us, but thank you so much for the session.
Thank you so much. Okay.
Yes.
Thank you so much, Shomwe, for that. It's a reminder. But I can see Sister Mbata is back. I don't know, sister, if now you are okay.
Thanks, Mr. Mahlangu. I'm okay. I think it's the network.
Okay.
I found myself, yes. Okay, I was saying I was appreciating the presentation. It's a good one indeed. But the challenge that we have is that in the communities or the communities, the families of these patients, of the palliative patients, they lack some information regarding these issues. For example, if ever I have a problem, where must I go socially, psychologically? They have those problems. I don't know how can we spread these messages to the community. Because even some of us, we find that we don't even know what we say. Okay, is there any social worker in this community? What should be done? Find that they call you as they know that you're a nurse. I have a client here, and my relative, I'm taking of the patient, have cancer, blah, blah, blah. But what must I do? Where should I go now? I think that's what I want to voice out.
Yeah. That's one of the gaps we have in our system when we look from tertiary to the grassroots of care. That, sometimes the information gap is there. Even if human resources have been deployed in some areas, but they are underutilized. Maybe one of the issues may be due that those people who are in the community, they lack that. But what could make clients unaware if they've been diagnosed by us, clinicians, and we know where the services are available? May it be that we don't share with them, or they forget, or we are reluctant at all even to talk about the palliative care issues, or even giving them the freedom to know if you want social work, this way you can get, because in some facilities they are there. Yeah, thank you so much, sister, to raise this point on information gap, especially in accessing these resources we are talking about, or in accessing the interdisciplinary team. Anyone else, colleagues, who may like to share or comment on the biopsychosocial spiritual assessment? Yes. I'm still looking, but I want to add that this model is to say we need to recognize that human beings are not just flesh and blood. They are social beings with social problems. They are psychological beings with psychological issues. And they are spiritual beings with spiritual issues. So, and whenever you get the opportunity to assess a client or to take care of a client, as the social worker has said, Messi said that, even though it's not your specialty, but we are having this session that we all have the basic skills to provide the basic care we can and be able to identify complex issues that may require a certain specialty and be in a position to refer. So it's very important that whenever we have a patient, we assess the biological, psychological, social, and spiritual. You know, I've experienced that sometimes in our hospital-based settings, as I'm sometimes a client to hospital setting, you'll find that you will be initiated into a certain treatment with ignorance on what exactly do you go through socially. And you find that some of the clients will end up with poor adherence. Some will tend to use the drugs for another use. We call it misuse, because we have not done that. You may find that sometimes clients may find themselves discharged. We don't know where we are discharging them. But I can see on chat a few comments. Cyprian Matsenjo says, for the presentation. I hope Messi is smiling already, Cyprian. Sister Mbata said that true patients are discharged without proper referral and leakage system. And we also lack knowledge regarding this. Oh my goodness. Hey, sister, that's why it's so painful, because in one of the studies we've conducted, we have found such findings that clinicians, they lack the knowledge. I don't know why, but we need to bring them here. You know, if you have a colleague, invite them to this session, they can understand what is happening in the country. But let's share the information. Let's invite our friends. Please join so you can know what is happening and whom you can contact. You know, we have Good Shepherd here who are looking the northern part of Lubombo. We have Hospice. We have Manzini Hospital. Today I don't see Nazarene. You know, RFM today has let me down. We have the regional coordinators here from Hospice. We have the National Referral Hospital. Patient navigator, a very strong guy. After the chickens are coming on your way, because when you are in the community, you are always mentioned. So you are doing a good job there. So we have these people who are trying to say, let's open the doors for our clients. Okay, let me stop talking. Anyone else who want to share with this model? Is it easier? I don't want to put you, Tandazile, on spot, but you know, your oncology unit is always in my heart. How has it been easier to practice this? Please don't disappoint me by writing before I've been asked. Cyprian, may I give you this opportunity before I read Tandazile's comment?
Hi, Mr. Manfano and team.
Okay.
Sorry,
Mr. Cyprian, wait a bit. May I hear Tandazile here?
Okay, sorry, mister. The reason I was using the chat box is because I have to see everything else. Give me a second.
Mr. Cyprian. Where is this?
Yes, Tim, Cyprian.
Okay.
I just to. Can you hear me now?
I can hear you now.
Yeah, I just want to share my case presentation. I have a client here with a breast and the breast related, which means the patient therapy having been diagnosed with breast cancer. So the oncologist go to the surgeons for mastectomy. Mastectomy was done and patient was initiated on chemotherapy. I would say, unfortunately, the patient couldn't respond to the chemotherapy and the cancer metastasized to different parts of the body. And now we're treating the patient for end of life. As a patient navigator, I had to reflect to other stakeholders like Red Cross, Hospice at Home.
We have lost you now. Mr. Matsenjo. Ungaba kuthi kulahlekana yini? The network is bad today. Mr. Matsenjo, can you still hear us, guys? Because I'm scared maybe we might be the one lost now. Okay, I've lost Matsenjo. Now I'm 100% sure. Okay. Tandazile, I've just lost Matsenjo, but you were saying a comment before you comment, may I read what you wrote here? Thank you so much for the presentation. We found it very helpful, particularly because it makes the client realize you actually see him beyond his clinical presentation or condition. It strengthens the client, care provider relationship and trust in the system. Yeah, holistic approach, the biopsychosocial spiritual approach into assessment and supportive care. But before then, you were commenting on something. I don't know if you can now, Tandazile, while I'm still waiting for Sipin to be back.
Yes, and thank you so much. Sorry, I'm our office is a bit easy. We have clients, so I'm in a different office and they're still but you'll be hearing the voice from that's why I had opted to chat. It's it approach that we are so strong to our coaching, and we are actually trying to use that. And we actually really helps, particularly is concerned, because now you're develop a lot with the looking at the beyond all now this actually what other than seeing this is which is it actually this candidate to actually feel like the person is and just keeping someone who is living with cancer. Yeah. What happens with from outside, you know, whenever people relate that but then if you me as a mother, but it tells me as who is expected to provide. You keep your mind relationship, you actually go to an extent opening up about a number of things that they mentioned to end up. Also, to issues like talking about end of life, putting their affairs in all, it makes the relationship and management a bit easy because okay, this one is not actually addressing these because maybe he thinks I'm doing, but they have consent of the word God. So it is one approach that we think it really works. How kind of make it in a way that if the office is moved, then it is that can take.
Right, I don't know whether, okay. Thank you so much, Tandazile. We're trying to get some of the words you are saying. I think, yeah, the network today is very poor in the country. It reminded me of some other times back when we had poor network. But we have seen that really this is one of the models we have to embark on in caring for our patients. I have another social worker in the house. So these days we are rich. I have Praise. Praise wants to say something too.
Thank you so much, Mr. Mahlangu. Mine is just a comment. Thank you so much, Ms. Shabangu, for the presentation. It was informative. My take home is that we should understand how the illness affects the clients holistically, how the illness affects the client, looking at the biological, psychological, social, and spiritual aspects of the client alongside the family.
Thank you, Praise. I don't know, I have 3 minutes left before we then kick to our case presentation. If I'm leaving someone behind to comment on this. So let's try this. For us to be able to take this approach to a high level when we are trying to implement it, may I say that for us as Hospice, it has helped us to have a good documentation. I would say good in our eyes, because we haven't evaluated it against other documentation from other facilities. But it has helped us very well, because then our documentation system enables the clinician, regardless whether I'm a social worker or a nurse or whoever who's in contact with the patient, as long as she or he will be using the documentation, then he is channeled or is guided on to follow the biopsychosocial spiritual model. So it has helped us to understand and put a clear understanding on how best we can at individual level and at a team level do or conduct spiritual, social, and psychological and biological assessment. So one of the things we have to do in our different facilities is to have some time, review the documents we are using for assessment. And these assessment tools we are using, or guiding documents, or our forms in our hospital, helping us to extract the biopsychosocial spiritual aspect of the patient, and then is our flow of patient and system of care in the facility, allowing us to channel the patient through the biopsychosocial spiritual care. That one then will help you to see that, oh, we missed this point, we need to add this way, we need this one, here we need capacity, here we need to do that. It helps you. I know colleagues like our fellow team members from Good Shepherd, they even when they are going for home base, they go together as a team. It also enables them that they can allocate each other's role, that, oh, today you are our spiritual person, or today you will be doing physical care, you will be doing social care. So they are able to allocate the roles to themselves and be able to do that. So we can do it, and it comes handy and so beneficial to the patient, the caregiver, and the family. All right, but I will say, request you guys to share whatever ideas you have on chat and whatever comment here on chat. We will appreciate that. But for now, we will move to our case. So I will request Mercy to build it for us so we can just share. So this is just a case we have seen yesterday. So I will be sharing a summary of it, and let's see, Pio is here. She will add if there's something I've missed. So in the documentation, I've just shared a summary. So I will be when is it coming? Is it coming? Okay. Yeah, you can further zoom it a bit. Plus. We are going into when we started. I don't know what it's not interesting. I think it's been lost. Okay, a bit out of benches. So this is the case that we have. As apologies, we want to sort something here on our side. There's something hiding here. Can you see the presentation now? I don't know if all of us can see it. Okay, so this is a 49-year-old woman, and he was admitted to home-based palliative care. I would say he was admitted to palliative care yesterday. So we saw her, and then we have time to admit her. And this was our initial visit. So we were there just to conduct some initial assessment, which then will enable us to prepare for how best we can support this client going forward. So I felt like it will be very beneficial for us as a team with the social workers to know what do you think we can do with this patient. So I haven't write anything more information on the document, but I will be sharing it. So this is the client. When we sit with the client looking at the diagnosis and the status of the patient is already at end of life. But then the issue is that the patient doesn't have a strong and reliable immediate support. So when we talk with the client, there were certain comments or complaints she raised. One of the issues was that this client doesn't stay in her marital home. She was once married, and in 2014, she lost her husband, and then she was then to live alone. Once then she has to live alone, there was the issue of the sickness that came and nobody could take care of her. And the fact that she was in his matrimonial home. So, you know, in our culture, when a woman is sick, the family then requests to take care of her and take her back home. You know that's practice that happens with us. So then now she's widowed. Unfortunately, during her marriage, she couldn't have a child of her own. So she doesn't have any children. So now she was back to have family, and where she complains of the severe weight loss that she has experienced in the few months with then unresolved anorexia that is continually being that is continuing to become more severe day after day. And now she's more frustrated because of the depreciating functional status, especially now she is not able to do activities of daily living, let alone the instrument of activity, the instruments of the activities of daily living, like going to the shop, the banks and stuff. So she's now almost bedbound with limited mobility, and she has begun to experience daily moderate pain and more severe. It's more severe at night. So during the day, when we were talking with her, she said that even though she feels the pain, she decides not to take any medication because she's saving the legal she has so that she can have more time to have the drugs with her. Thus, she's experiencing more severe pain. And now it is accompanied with episode of nausea and vomiting, which is worsened by taking any food. And she is now feeling fatigued or tired, even at rest. So that's what she was complaining about. So in short, she's complaining of a loss of self-image due to cachexia and anorexia and the moderate to severe pain. And then she's complaining mostly of the isolation by her loved ones. And then the consistent nausea and lack of food and support. That's what she was complaining about. And then she complains of the pain that was somatic and it's on the lower abdomen, and 6 out of 10 during the day, and then sometimes it escalates at night. So she has been taking some chemo, and then the chemo helped her to have some time to sleep as it reduces the level of pain. Otherwise, she will experience difficulty to initiate sleep or let alone manage a sleep. So the pain is chronic because it has exceeded 3 months now, and it's more aggravated by any movement. And the only way she could relieve it non-pharmacological is to take a sleep, of which when we were looking at the coping mechanism, this is one of the maladaptive coping mechanism that she adopts to, and looking at her condition. So yeah, she sleeps. The only thing she can do is to sleep in the bed in the house. And the functionality status at state when we found her, she's already an ECOG 3. So she can feed herself, she can bath her face, but she cannot do other things other than sleeping on the bed. And then we found her on non-opioids. She was taking fixed dose combination, a dose of paracodaine, and she said that she bought them from what we call this over the counter, and she takes only 1 tab of it, of which we know that one, it means it's a Panadol, 5 milligrams and 10 milligrams of codeine. And she said, yeah, it does help her at some point, but sometimes it doesn't. And then, but we found that she was once initiated into tramadol, and we found that she was left with a few tablets of tramadol. And then when we look at her physically, she's looking so sick looking and chiastic, you know, skin dry, bedridden, dry lips. And because of the chemo that has just been withheld, there's alopecia and moderate to severe anemia, especially on examination of the mucosal membranes. And then also when you touch the fingers, there's a delayed capillary refill. So we can say that there is some elements of dehydration because she's not taking enough fluids after that, because anything you take by the mouth, then she vomits. And then she also complains that in the gut, it feels that there's a tumor also in the gut. But when we examined the throat, there was none like a tumor there. But she said that whenever she's eating, he feels like there's something also by the throat there. So, but we couldn't tell what is inside because we couldn't do esophageal tube examination, like get an horoscope and see what is inside there. And then when we look at the psychological aspect of the patient is looked very frustrated and stressed and a little bit of some depression. And this one is more correlated with the isolation and the loss of functionality with the loss of self-image due to this refractory anorexia and cachexia. And when we look, when we ask about history of occupation, now currently she's unemployed and she's surviving with the money she saved while she was a domestic worker. So now she's eating those savings, and those savings, she clarified that when she was working, she saved a little of some money so that she can build herself a home or a house. So now she couldn't build that house and is now using that savings for survival. So, and you can imagine that she was a domestic worker cleaning in the house of the boss. And then education-wise, she has finished her Form 5 and economically very low class, very low class. Situation is bad financially, and the marital status widowed. And when we ask her about any history of non-health habits, there was none that has practiced, no smoking, no tobacco, no anything. And at her time, she was reported to be one person who was an entrepreneur of some sort, an active woman who fights for her life, to striving hard to be financially stable. But now, because of the status she is in, she cannot do anything. As I've mentioned that socially, we found that there was no caregiver in such a way that she couldn't even give us one name of a person she can say she relied on for care. Even though now she's bedridden and totally dependent on other people to support, cook, clean, wash for her, she said she doesn't have any caregiver. When we found at home, we found an elder brother. Yeah, it's an elderly guy who's approaching his 60s already. And he said that that's the only person who usually washes her clothes. And she said that she's not comfortable that the man will wash her clothes. You know the culture. Ladies, there are clothes she cannot give to the brother to wash. And he is the elder brother. So look at her. She's 49. Then if the elder brother is the firstborn of the house, it means he's the very old. And I've mentioned that she has left her home alone, where she has started building with her husband, and nobody's there, even though she reported that she sometimes requests neighbors to check for her, but she wished she could go back to her home, but the situation she's living in due to the condition is stopping her to achieve that. And then I've mentioned that she has lost her job during COVID, so the grief of loss of job and plus this one also has predisposed her to severe stress. So she also reported to us that sometimes she spent days without food, not that the food is not in the house sometimes, but because nobody will cook. She mentioned that at some point she will try to stand up on her feet to cook for herself, but she will fall many times and then she will end up giving up and then sleep on an empty stomach. So that was the case. And sometimes those she lived with, the siblings and the sisters-in-law, they leave her alone and not report where they are going. Even when they are in the house, they don't even engage her, or in the home. She will hear them talking outside, but not involved in it. So she feels very isolated. But when we look around spirituality, she mentioned that currently she survives through God, and she prays whenever there are problems, she prays, and prayer has worked for her. She shared a certain testimony with us that has motivated her to keep on believing in God, and she still believes God, even though the condition may not be reversed, but God of miracles can still cure her and give her another chance to live better. That's what she still believes in, and she still believes God can do better for her. So what she practices, she reads the Bible and she prays. Unfortunately, when we came, we found that the Bible she usually reads, she has left it in her matrimonial home. So now currently she doesn't have, and she usually reads one in the phone. But the phone she was using to read the Bible was destroyed during charging at a neighbor's home. So now she doesn't have anything to read. So yeah, for that reason, we arranged that maybe we could get one from the community health care workers whom they provide. They said they would do. But when we gave her that option, she said that no, she will try to organize that they bring her own Bible from her matrimonial home. So we are still hoping that she will manage to do that, and they will bring her it for her to read, because that's only what she has. And she said that that's the only thing now that keeps her mind busy, because if the Bible is here and the prayer, she feels better. So when we look at the history, this client has been to hospital many times for low abdominal pain, and there was a cyst growing in her uterus. So she has been to hospital, to another hospital, and there have been options for surgery, but they were not done. So, and later last year, it happens that the tumor has grown that big, and she's not happy that now when she was diagnosed in November last year, she was told now she has cancer, and the cancer now is stage 4B. It hurts her a lot because she felt like the health system has let her down, because he has been with the health system many times with the same complaint, but nothing was said about cancer. They were saying they see nothing, the tumor is there, but it's not cancerous. But now they are telling her that the cancer is stage 4, and it has gone, and the way she said that they told her that the cancer has eaten her up. That's what he told us. He said in Eswatini, cancer is simultaneously. That's what they told him. She told us. So now she was initiated in chemo last year on diagnosis. She has taken 5 cycles yet, but around May, she was told that she will not continue with the chemo, and then she was told maybe must come back around August to see possibilities. And unfortunately, they've never told the intention of the chemo at this point in time. She don't know, but was told it will be told that it will wait until August. So we were suspecting, looking at the status of maybe clinicians found that maybe it is not going to be beneficial at this point in time, because he has lost of weight and the chemo makes her very bad. So maybe that was our assumption with her, but we never shared with her that issue. So that's what she told us. So current medications he's taking is the tramadol and the paracotin, and she was on supplements. She was taking ferrous sulfate. We found that she was only on ferrous. There was no folic there. And then she was taking metoclopramide. What we noted that even though she's taking the metoclopramide, the nausea and vomiting continues. So then yesterday, we introduced to her the opportunity of advanced care planning. Actually, we asked her if he has an advanced care plan, and she said she's not yet in a mood or ready to discuss such issues. Maybe if later she will. And then we asked her also about sexuality issues. In our screening, she said, yeah, she understands the importance of it, but at this point in time, she feels not ready to discuss such issues. Maybe she will give us time in future. Maybe she will be able to discuss such matters. So when we dig down in the past history of the patient, we discovered that her mother died of breast cancer. So, yeah. So we had concern, though, in terms of the advanced care planning, looking at the way the patient is descending the trajectory of the condition, that maybe the future will come, but we might have lost the opportunity to discuss the advanced care plans with this patient, because looking at the condition she's going through now at end of life, we might find that tomorrow is not able even to talk. So we don't know what will happen in our next visit to her. But these were the vital signs we found with him. Looking at the history of the vital signs, there was not that much abnormalities we have seen with her, except that the BP was a little bit lower than compared to previous BPs. And I've mentioned that she was already on ECO3, and the pain that is moderate to severe, with a little bit of anxiety and with moderate depression, which may require more psychological support from the caregivers and the family. And then with this severe nausea and cachexia, weight loss, and anorexia that we have seen with poor mobility, that this patient is facing at this point in time. Maybe we go to to our interventions. So we didn't do much because this was our initial assessment. What we did, we found that the patient was mixing the paracoden with the tramadol. And then we educated on how to take these opioids. And then we educated on not to take them only BD because the dosage that he has are only to be taken 8 hourly or 6 hours. So we encourage her not to mix the two opioids, to take one, not to mix them. And then we also educated on how is it important to take the tramadol 8 hours. Yeah, so that's what we did, and we educated on the importance of taking the supplements. And for that reason, we also prescribed other supplements that were missing, and we prescribed more metoclopramide, and we encourage you to take the metoclopramide at least before taking the meals, and then take the meals. And we encourage her to continue to take soft meals. We found her that she has bought herself Future Life, so that's what she's now trying to eat. However, the unfortunate thing is that one of the things we found is that the house is untidy. So there's food everywhere that he has not eaten. That we find that this one he bought, but he never ate. He bought this, he never ate because of the appetite issue. And then we enrolled her into prednisolone, 10 milligrams for 5 days. So for that reason, we will call her after 5 days to review and see how has the anorexia responded. And also we are targeting the issue of cachexia, but though it looks refractory now because instead of it improving, it's worsening. Yeah. We also engage the community available interdisciplinary team because that day, this client was referred to us by a community healthcare worker or volunteer who referred to us, who happens to also do check on the patient. So she's the one who referred to us. She was not referred by the diagnosing and the chemotherapy team. So it was referred by the community worker. So then we requested the community worker to support her. And then she said she is willing to and open to any spiritual community that will come to support her because that's what she wants at the most at this point in time. So the community caregiver said she will arrange with the pastor and other Zion members of which she was part of that clergy. So to arrange for her, and she appreciated that, and we are hoping that one will be successful, and also in organizing in outsourcing the Bible. And also we encourage the brother and the family to work around the issue of isolation. We encourage them to be with the patient at least on the meal times because she complained that even evening, nobody comes to greet her. So that at least in the evening, if they are home, they come and share moments with her and greet her. And even when they are leaving the house, they also inform her what they are doing. And we did reassure her of our support, and we are still to sit down and see what best we can support her and go back and visit her. So we were requesting your support, colleagues, that what can we do for this patient as we are planning to support her. Thank you. Maybe you can vululisa us, colleagues. What can be done? This is the scenario of our client. Maybe you can help us do better. How best we can support this one? Yes, help us do better. Section. Yes, if you can, colleagues, how best we can, if you have something to give us on what we can do. Otherwise, that we try to mobilize the community resources and request them to frequently visit here and organize and requested the caregiver. Another thing, she said that she doesn't like to have external people from her home to visit her because people then go around talking about her, of which she doesn't like. So that's one of the challenges. Whenever you need to bring someone in, you need to give her the confidence of confidentiality. Yes, colleagues, we can appreciate your sharing ideas. Help us do something with this one. To the end of life care, not willing to discuss end of life, not willing, but the only thing she's looking for spiritual care and maybe support with. And she said that she will be going to hospital at some point, but it charges a high amount of money because she has to hire a taxi from home to hospital. And if she do hospital visiting, either go to Babane or Peace Peak. I don't know if you get what we share, but that's what we tried yesterday. Maybe if there are things we feel we need to check and add, colleagues, we can appreciate that so that when we go back, we also do that. Anyone wants to share? Hello, colleagues, did you hear? Yes, Margaret Gamenza.
Thank you, colleagues. Thank you for sharing this case, Sandile. I think you said it was your first time to see her yesterday.
Yes.
Did I get you? Yes.
Yes.
So I think on that issue of discussing, you said end of life,
Yes.
or you said directives.
We were saying
She was
that,
not.
yes, she was not. We asked her if she had any advanced care plan just for life, whenever, because
Yes.
she said she's aware that because now the case has eaten her up, she might die out of it. Then we asked her if she has any plan to prepare for the future and the wishes she has. She said not ready to discuss that yet, with the fact that she believes God can still heal her.
Okay, thank you so much. I think it was her honest answer, more so because it's her first time maybe to be confronted about the issue, and it was your first visit. So I believe now that you have proved thinking, she'll be, if you get an opportunity to see her, I'm hopeful that she'll be more willing to discuss the issues because they've thought about them and in a left man that shows someone to think about today, and knowing ultimately this will be the end. It's not easy, but thank you for probing her. I believe next time she'll be willing to talk about it. Thank you so much.
Thank you so much, Maga. We will do consider maybe prioritizing that, maybe go back there again and check if she's willing it. Yes, I don't know. Anyone to say something? Anyone wants to share something, colleagues? You want to say something, please? Oh, okay. All right. Anyone wants to share something, colleagues? Vunulisa asks, or any question you may have for us as a team who went there. There's my partner in crime here. She can also answer where the loopholes if you have any question. But this is one of the cases we have had yesterday. Yes, Mavuso Tebandla.
Thank you, Mr. Mahlam, for the case presentation. I don't know if it's possible that we engage the maternal and family members so that they give her the support that she needs, because with whatsoever that's happening, I feel like it will be best and much to her advantage to get all the support that she can get and feel the love and feel supported during this time.
Simple will answer that one. Yes, please.
Thank you so much, Mr. Matlang. Mine is just a suggestion, with him. We can volunteer to clean the house. Yeah, but of course we need to ask for her consent, yes. And we can also engage the brother and to encourage her and educate him on how to take care of the ill sister, because the sister needs all the support. Yeah.
Thank you. Cynthia is here. She heard you very well. If you want to go there to the cleaning, maybe possible the cooking again. I know. Yeah, maybe Cynthia, I don't know if you wanna respond to the two. I don't see anyone else raising in this. The only thing I can see is a plus sign from Tandazi. Yes.
Thank you for the comments, Stephen, and praise. But when you praise, the brother is involved. Problem is he doesn't stay home. He works. Luckily, he said that we found him there because he don't live. So he tries his best to take care of the sister. Unfortunately, he always has to bring something home.
Yeah. And also for Tebada, she said that the maternal family does come sometime to check on her, but it's not something frequently. They come, you know, the Makaya way.
Yeah.
So, yeah.
And also it's because the ones from her family asked her to come back because in her maternal home, she stayed alone. No one took care of her there. That is why she was.
I can see Sitegi, Good Shepherd. Anything you can vulnerabilize us with?
Yes, thank you so much for sharing this. And they say great minds, they think alike.
Yeah.
I think we have already done like his talks to the holistic that you were talking about earlier. I just want to ask a question like on the spiritual part. Like I heard that you said the patient is positive, like she believes in God and everything. I want to ask like if there was a point like in life, maybe she went to a real church, like does she have a church? If she does have it, like have you like maybe taken the initiative like to conduct some of the maybe all church members? Because I remember a case we had such a case whereby the patient, it was like this one, like there was nobody to take care of her, nobody wanted to take the initiative to look after her. Then we went to the church that she used to go to about maybe 4 years ago. So you can imagine like it was a long time ago. But luckily when we went to talk to the pastor, they were so touched. And some of the church members, they even volunteered that they can cook sometimes for the patient. They can bring food like on a daily basis. Like I just want to maybe share an idea, like if you can go on that road, maybe there can be some people who can volunteer from the church if it is there.
Yeah. Thank you so much, Shom. I don't know if my social worker can answer that one because, yeah, there's something we got on that aspect.
Thank you so much for the comments and on what we can do. Unfortunately, the church she went to is falling apart. She said there are only three members left, and they do come to check up on her when they get time. That is why she said that can other churches come and share the word of God. And also Marga Piri, the one who referred to us, said she would also talk to her church members from the Nazarene in Eswatini to see what they can be helping her. And she will also try to bring her daily because
She says she comes twice a week. So she says we try to spend more time with her.
Yeah. Yeah, that's what we found there. We asked about the church, but we got that also it frustrates her that her own church is in shambles, it's breaking down. And she was one of the, I don't want to state church members, but she was one of the committed members to that church. But with the breakaway, she also appreciated that there are those few members that are left, that are 3 now for the church that are coming. But with her permission, as Simple is saying, the community caregiver promised to engage her own pastor. Now that she knows that the client is open to any pastor, she will engage her and see how best they can support her. And she appreciated that so much. Thank you so much, Ngozi. And we will still explore such issues going forward too as a team, how best to engage the church in doing that. I can see Tadazle saying that thank you so much for the case presentation. Personally, I am like, wow. And I see Mrs. laughing and Simpi okay. You guys did great job. Just one quick one. How do you guys handle the issue of end of life without taking anything away in as far as their faith and hope is concerned? I don't know. But jokingly, what we usually do is that we allow the patient to lead the way, and we ask them questions that will help them reflect on themselves, and we share based on their concerns. So it helps us. For example, we ask them about their condition, and then the person shared that they told her that the cancer has eaten her up, and then we asked her if you understand what does that mean. She told us, and then she said that this might mean she might die out of it. And then the issue that the patient understood that there's death coming on the way, it helps us then to begin to ask the question that, is there anything he has put in place to safeguard my wishes are going forward? Then she begins to share, and then we asked her, what is the most important thing? She shared that the spiritual part of it, church reading, that's how then we maneuver through the issue of end of life. Otherwise, initiating something is very difficult. But you know, with practice now and then again, you start slow, start once, make it wrong, next time you do it well. And sometimes having people in your presence who do it, you learn from one another. And then it's very nice when you have a team, because you use your strengths on how best you can support the patient to maneuver the journey. Otherwise, having open-ended questions and flowing with the patient is very good, and it helps in that way. As this was our initial meeting with her, as Martha might have said, that if we can go back, because now we have initiated it and she has initiated the issue of death, we can build on that. And then when we come back, we bring it back. Last time you said you are not ready to discuss these issues, then we see if there are any issues and concerns she has. Okay, so thank you so much, colleagues. Thank you so much for this session. We will do a rebusela, of breaking bad news in this module. So in our next session, that will be held on the 3rd of July, 2024 at 1 p.m. We will be having an opportunity to revisit talking about bad news, like this one that we had yesterday. We will have an opportunity to look at them on how do we go about this news, how do we go about it. And thank you so much for sharing with us what we can do. I hope my social worker here will take what we have said and also what you have shared with us. We are hoping we will be able to share feedback on the 3rd on how far we have gone with this client. So we are wishing to do the best for her at all our costs as Hospice at home and with the team that we have in the community. Let's meet on the 3rd of July, 2024, where we will be doing breaking bad news. How are we going to tell them that now, because we have never talked with the brother yet, that what they see with the client, what they're anticipating with the condition, if then we break the bad news with the consent of the lady. So that's what we are going to be looking at. For the purpose of us to be able to provide good psychosocial support, we have said that we will bring back this presentation on breaking bad news. Thank you so much. Wishing you a good day, and may God bless your hands as you touch those who are sick. Thank you. Bye-bye. And when you are exiting, please click on that link that we have shared and share your feedback with us.